السلام عليكم، كل عام وانتم بخير جميعا. Presenter, can you prepare your slide? Or panelist, can you start your introduction, please?
السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام.
Are we starting soon?
Can I start?
Yes.
Okay, perfect. Assalamu alaikum everyone. كل عام وانتم بخير. Today we're going to be talking about physiology and diagnosis of aortic aneurysm. I'm Already Tabeti, R1 in King Faisal Specialist Hospital Research Center from Riyadh. The content that we're going to be going over today, we're going to have small introduction, then talk about physiology and then the diagnostic work.
Walid, go to the slide mode, please.
Okay. Sorry. طيب, small introduction. Okay, before defining, okay, yeah, so for definition of aneurysm, good agreed upon definition for the true aneurysm is segmental full thickness dilatation of more than 1.5 of the original size of the vessel. Now we can have either false aneurysm or true aneurysm. As mentioned, the true aneurysm is usually dilatation of all components of the vessel wall. However, the false or pseudo aneurysm, it's usually only the outer layer of the vessel wall. For the true aneurysms, sometimes we have different morphologies. If we have only dilatation of one side of the vessel wall, it's termed saccular or saccular, and if we have dilatation of all sides, it's usually called fusiform. Now I mentioned that aneurysm is defined as increase in 1.5 of the original size of the vessel. So that means we have sizes for the different components of the aorta. You can find different numbers depending on the sources and the articles. These are average dimensions that I found in one of the articles. Obviously, the dimensions are different depending on age and the size of the individual. Usually, the males having bigger dimensions than females, and within the same gender, the size matter as well. So, bigger individuals usually have bigger dimensions. And each section of the aorta, you can see that have already established or agreed average dimensions that we assess the suspected aneurysm to. These are useful images identifying all sections of the aorta and with its sizes. Now, just a review of the different sections of the aorta. We have what is below the diaphragm is usually termed the abdominal aorta, and what is above it is the thoracic. Now, going from the start, from the aortic annulus till the sinotubular junction, this is usually aortic root, termed aortic root. From the sinotubular junction till the brachiocephalic first branch of the aorta is called ascending aorta. Aortic arch is what is between the brachiocephalic and the left subclavian. And from the left subclavian till the diaphragm, this is usually termed the descending aorta. Today, the discussion is mainly going to be about the thoracic aorta. Even when we talk about the pathophysiology of the aortic aneurysm, the pathophysiology behind those two pathologies are completely different due to the different structure of these two segments of the aorta and the different component within them. So today we're going to talk about the thoracic aorta, having the main cause being degenerative cause. Now, before talking about the pathophysiology, talking about the normal structure of the thoracic aorta, the aorta has the structure of the usual elastic, big elastic arteries. So we have three main layers with two elastic layers in between. The first layer is the tunica intima, which is mainly made up of endothelial cells. This is in contact with the content of the lumen. After that, we have the internal elastic lamina or internal elastic layer. Then we have the tunica media composed of smooth muscle cells and different elastic fibers. Then external elastic lamina. Then lastly, the tunica adventitia. Now, our main focus today is going to be about the tunica media and what can occur within it, as a lot of changes within it is what eventually leads to development of aneurysm. Now, the tunica media is composed of many alternating layers of smooth muscle cells, elastic fibers, different extracellular matrix components such as collagen and whatnot. I want to put more focus on the elastic layers of the tunica media. Usually these are made of elastin, two elastin sheath. You can see it on the right, that is sandwiching a collagen layer. Now, both of these components have different functions for the aorta. For example, the elastin is the main component that is responsible for the distensibility of the aorta. And the collagen is usually for the tensile strength. So what do we mean by that? For example, during systole, after the ejection of the blood from the heart, the aortic wall will be expanding. That is the function of the elastin, but it will only expand to a certain point. And what is keeping it from rupturing, what is giving it its structural integrity is the collagen. Now, failure of the collagen at that point will lead to eventually to the rupture. Now, all of this is very tightly regulated by many mechanisms within the body. A useful frame to have in mind, especially for the thoracic aorta, is to have the idea of promoters and antagonists for development of aortic aneurysm. Now, this frame works for degenerative causes of aortic aneurysm. Those are being the main causes of aortic aneurysm, thoracic aortic aneurysm. However, even within the genetic ones, different components of this frame will be the reason or will be the culprit for development of the aneurysm. Now, talking about this frame, usually the antagonists and promoters are in very tightly controlled balance. However, when the scale is tipped toward the promoters, that's when the aneurysm ensues. Different promoters for the development of the aneurysm could be for example, aging. Aging plays important role. I mentioned before about the elastin and collagen differences. One reason for mentioning those mainly, usually with the age, when an individual ages, the ratio between those two components are disturbed, favoring collagen. Not only increased collagen, but also increasing in certain types of collagen. That leads to the loss of the distentability of the aortic duct, the aorta. That's why the aged population usually have a stiff aorta. Aging is not only characterized by changes and alterations within these two components. There are a lot of changes that occur within all components of the arterial wall. Another promoter for the development of the aneurysm are the elevated blood pressure and the wall stress and the different neurohormonal factors. One other promoter I want to talk about is the matrix metalloproteinesis. The metalloproteinesis are basically proteolytic enzymes that are secreted by the different components of the tonica media. These proteineses are basically able to melt every component of the tonica media. And to combat these effects, they are usually tightly regulated by some other component that we're going to come across when we talk about antagonists. Now, plasmin is involved into a lot of pathways that the end results of them basically is the activation of these metalloproteinases and also the degradation, direct degradation of different extracellular components of the arterial wall and also the smooth muscles. Now, last point is about platelet and prothrombin activation. Those are platelet and prothrombin is found activated in the aneurysmal tissue. It's not really sure whether that's a cause for the aneurysm or it's just a result. Now we mentioned the promoters. What about the antagonists? We mentioned the metalloproteinases. Now we have something called the tissue inhibitors of metalloproteinases and something else called microRNAs. Both of these work in hand to oppose the effects of these metalloproteinases. And usually, if there are any issue with the balance of the action of both of these things, the end result is development of aneurysm. As mentioned before, there are also different components of the arterial wall, elastic layers, collagen fibers, fibronectin, and whatnot. All of these and the integrity and the normal structures of these usually are found to be altered within the aneurysmal tissue. For the causes of aortic aneurysm, it's the major cause being degenerative. However, we have aortic aneurysms that are developed due to genetic alterations. The genetic alterations are usually within the previous components that I mentioned in that frame of promoters and antagonists. These genetic alterations, some of them are syndromic, such as Marfan syndrome, Ehlers-Danlos, and whatnot. Some of them are also familial, but not syndromic. There are many different genes. There are a lot of tables for these genes that you can find in different articles if anyone is interested in. There are other causes for development of thoracic aortic aneurysm. Bicuspid aortic valve is well-known risk factor and as a direct cause for the development of the aortic aneurysm. Different connective tissue diseases such as rheumatic heart disease, SLE, has been also some of the rare causes for development of aortic aneurysm. Some ortitis and different forms of vasculitis such as Barrett giant cells and Takayasu has been also implemented. And then lastly, infections, namely syphilis, and sometimes even endocarditis. Now we came to the second part of the presentation. For the diagnosis of aortic aneurysm, it's generally asymptomatic. And it's usually discovered incidentally when a person is doing some form of imaging for a completely different reason or discovered catastrophically after complications has occurred. If the patient is gonna have some symptoms, usually symptoms are due to the complications, so chest pain in cases of dissection, rupture, or symptoms of heart failure when, for example, we have dilated root and aortic regurgitation and whatnot. Other form of symptoms of compression. Now we'll go over some of the symptoms for the compression. Now the compression can occur at any point of the vessel wall, and depending on the site and the involved structures will have different presentations. majority of these are very, very rare, so they are not usually encountered in your usual medical practice. Some of the structures that are involved, for example, coronary artery. These are images from a person who had angina and episodes of syncope. Upon workup, he was found to have dilated. Sorry, not dilated, but sinus of Valsalva aneurysm. On CT, it was found that this aneurysm is compressing the LAD. So after surgery, what they did excision of this sinus of Valsalva aneurysm and patch repair. You can see in this cath image the sinus of Valsalva aneurysm that is compressing the left main. There are other symptoms. There is another entity called dysphagia aortica, where the aneurysm is compressing the esophagus. This is from a patient who had dysphagia. In chest X-ray, you can see clear cardiomegaly and ascending aortic aneurysm, even shown in the CT. On barium swallow, it's clear that there is an issue with the distal esophagus with this barium study, swallow study. When the nerves are involved, it depends on the nerve. Sometimes you can have diaphragm paralysis or sometimes hoarseness of the voice. This is from a patient that had hoarseness of the voice. He was found to have saccular aneurysm just inferior to this origin of the subclavian artery. And we know from anatomy or study in anatomy that the recurrent left recurrent laryngeal nerve courses just in that area. So this patient was presenting with hoarseness. When the tracheobronchial tree is compressed, sometimes the patient will have different infection, respiratory infections, or shortness of breath. Sometimes the aorta can compress the SBC, leading to the well-known superior vena cava syndrome, with the patient having upper limb swelling, plethora, and whatnot. Sometimes the patient will present with due to compression of the different branches, so either arm upper limbs claudication or even stroke, such as this case where there is a saccular aneurysm that is compressing the what seems the left common carotid artery. Now, upon review of the patient history, sometimes there are some background conditions that may hint toward that the patient may have, or basically these are conditions that are found to be associated with aortic aneurysm, and it may raise your suspicion of such diagnosis. These conditions, such as some of them we've talked about, like bicuspid aortic valve, connective tissue disease, intracranial aneurysms have been associated with aortic aneurysm, renal cyst and inguinal hernia, and some of the aortic arch branching abnormalities, such as bovine aortic arch and whatnot. But family history clearly is very strongly a strong predictor of the possibility of having an aortic aneurysm. On physical examination, usually you'll find features of some of the high-risk conditions, the syndromes that we mentioned before, such as Marfan and other forms of familial genetic disorders, or you'll have features for the original pathology, that is aortic aneurysm. Vitals may show, obviously, majority of these signs will not be present in a lot of patients, especially if they have stable aortic aneurysm. However, if you were to find anything, you may find wide pulse pressure due to aortic regurgitation, sinus tachycardia, or hypotension, or other findings. SBC syndrome, findings such as plethora in the face, upper limb swelling, and Pemberton sign, which is a sign found in severe vena cava syndrome. Focal deficits and deficits due to stroke, due to compression of the carotid artery, can be found in neurological examination. Cardiac examination may reveal aortic regurgitation murmur or some pulse deficits. Up to date, there are no markers that have been reliably used to identify the presence of aortic aneurysm. It's an area of evolving research, but as of now, there is nothing. General workup may hint towards some of the complications that may occur during aortic aneurysm. For the diagnostic study, probably the most the gold standard is being the CT. However, usually patients who present with vague chest pain, which can occur sometimes with expanding aortic aneurysm, they may undergo ECG. ECG is usually not lucrative, but it may show left ventricle hypertrophy due to AR, evidence of ischemic heart disease. Echo is useful image, especially for serial monitoring, since you avoid the use of radiation. However, there is one limitation of the echo, that it's not reliable in imaging all aspects of the aorta. So even if you could not diagnose the aortic aneurysm through echo, that does not exclude the diagnosis. Chest X-ray you may find ascending aortic aneurysm. However, aortic root aneurysm are usually not easily seen, as they are usually obscured by the cardiac slough. CT and MRI are clearly very advantageous in identifying all aspects of the wall and determining the size. The drawback of using the CT, it needs contrast. So sometimes there are and also the radiation. So the use of CT for serial monitoring, although it is used, but you need to keep that in mind. CT and MRI are both useful also in assessing not only the dilation, but also if there are any acute pathologies. Now, with the CT, you need contrast. The issue with not using contrast for the CT is you will not be able to find some of these different pathologies, such as dissection and whatnot. These are good tables that are found in different guidelines for aortic diseases, identifying the different advantages and disadvantages of the different modality. Now, clearly, some of the pathologies, some patients may require surveillance for aortic aneurysm, and even sometimes background conditions such as Marfan syndrome, bicuspid aortic valve, and whatnot may require at some point surveillance for aortic aneurysm, despite not having it. This is a topic for another discussion, and usually can be found in the guidelines of these different conditions. These are the references used in my presentation, and that's the end. Thank you for listening. Anyone has any question or feedback regarding the presentation?
Thank you, Dr. Walid. Very well presentation and informative. I'd like to welcome Dr. Rida Jamjoom. Dr. Rida.
ايوه السلام عليكم.
وعليكم السلام ورحمة الله. مساء الخير يا دكتور.
مساء الانوار، كيف حالك؟
كل عام وانتم بخير.
الله يرضى عليك وانتم بالصحة والسلامة جميعا.
تفضل الله منا ومنك يا رب.
آمين يا رب.
Dr. Rida Jamjoom is a consultant vascular surgery at King Abdulaziz University Hospital. He is our guest today. So Dr. Rida, if you have any comment, just go ahead.
أولا thank you for this والله very informative presentation for things that we يعني تذاكرها وقت الاختبارات وبعدين كثير تنساها، خصوصا الباثوفيسيولوجي والجيناتيك والكولاجين والاشياء دي. I loved it. I love the way you present. I love the way you أنا I really enjoyed your presentation حقيقة. الله يوفقك. بالنسبة اللهم صل وسلم وبارك عليه أنا mainly طبعا على descending والنيو era طبعا اللي in the last few years اللي هي حقة الأيورتيك arch والendovascular intervention في الأيورتيك arch. ففيها بيج روم والستنس بتتغير كل سنه وبيطلع اشياء جديده واشياء هذا. فالله يوفقك. I loved your presentation. شكرا لك.
Thank you, دكتور. يعطيك العافية. أشكر. This topic is going to be presented, but I think at later time.
Okay.
The next
تمام.
lecture would be about the endovascular management of the thoracic disease, aorta disease. شكرا دكتور رضا. Anyone has any comments, question for Dr. Walid? So I think we will have a 10 minutes just break, and then we will be after 10 minutes, inshallah, we'll resume our activity. Dr. Rasha, just be ready for your presentation. Thank you.
اوكي ان شاء الله.
دكتورة رشا.
Yes.
Yes, please go ahead if you are ready.
Okay. طيب يلا let's start. السلام عليكم. المفروض المحاضرة هذه تنعطي الأسبوع القادم بعد ما الأسندنج والديسندنج ديزيزز كلها تنشرح، ولكن لظروف ما اضطرينا نقدمها. فاحنا حنتكلم عن الاندوفاسكولار ثيرابي فور ثوراسيك اورتيك ديزيز اونلي. الابدومينال اورتيك ديزيز حيتكلموا عنها في المحاضرة الثانية. Okay. So our objective, we'll start with the introduction, and we'll talk about main 3 diseases in the thoracic aorta, which is the aneurysm, dissection, and penetrating ulcer, and in general hematoma. In the aortic aneurysm, we'll talk about the natural history, indication, anatomy, the landing zone. When we cover the left subclavian artery, complication, most common complication. The dissection also, we're going to talk about the indications, goal of treatment, and how to deal with the different type of dissection. So introduction, thoracic aortic disease, it has many challenges as the patients mostly are very old age and has a multiple comorbidity. Also, the location of the descending aorta is challenging in the opening surgery. So in the alternative to limit the morbidity and mortality for the open surgeries, we use an alternative method, which is the endovascular, that has already shown a good long-term durability and steady improvement in the symptoms of the disease. So we're going to start with the normal dimension of the aorta. As you can see here, are ascending usually 2 to 3 centimeters, 2.5 to 3 centimeters. Descending thoracic aorta usually 2.5 to 3 centimeters. This is the normal diameter of the aorta. Descending thoracic 2 to 3 centimeters. Abdominal aorta till the diaphragm is 2.5 centimeters. So when we start with aortic aneurysm, aneurysm is usually defined as dilatation of any artery more than 150% of the normal caliber. فإحنا لو قلنا هنا إنه النورمال aorta مثلا في descending thoracic 2 to 3 centimeter, so it will be classified as aneurysmal if it is 150 dilated than the normal. يعني هيطلع 150 يعني 1.5، يعني نقول starting from 4 to 4.5 is called aneurysmal dilatation of the aorta. 50% of the aneurysm are located in the descending aorta to the left subclavian artery, which starting from here. The risk of rupture within 5-year risk is 30% for the thoracic aortic aneurysm. So what is the natural history usually of the aortic aneurysm? If left untreated, it has a high risk of rupture, as we said, 30% within 5 years. The expansion of the aneurysm occurs at a faster rate in larger aneurysm. It's almost 0.2 centimeter expansion if it is less than 5 centimeter, compared to 0.8 expansion per year if it is more than 5 centimeter. And the risk of rupture also increases with the size. So it's 0.3% risk of rupture if the aneurysm is between 4 to 5 centimeters, and increase up to 3.6% if the aneurysm size is more than 6 centimeters. The median size of rupture usually 6 for the ascending and 7 centimeters for the descending aortic aneurysm. So what are the indications for intervention of the aortic aneurysm in general? Diameter more than 5.5 to 6 centimeters is an indication for surgery because it has high risk for rupture. And Also, the circular morphology, we have, of course, two types of morphology. You will know it later on in the lectures, but the circular morphology is an indication for intervention. Rapidly expansion more than 0.5 in 6 months or 1 centimeter in 1 year is also an indication for surgery. Symptomatic aneurysm like refractory pain despite maximal medical therapy is also an indication for surgery. Evidence of limb ischemia, spinal cord perfusion, signs of shock, all these are indication for surgery. So this is the summary of the guideline of all the society. As you can see here, all of them is the same indication for 5.5 centimeter. The sacral aneurysm, the width of the saccular, if it's 2 centimeter of the total size of the aorta, يعني إذا كان الساكل aneurysm السايز بتاعه 2 centimeter of the total aortic size of 5 centimeter, this is an indication of intervention. And for the yearly surveillance imaging, if the size is stable, we can do it every 1 year, and it's continue to be stable every 2 to 3 years. And Canadian guidelines says 6 to 12 months after the diagnosis, and then every 6 to 12 months, depending on the size, if it's stable or it's increasing in size. So the anatomy important before we take the decision that the patient is suitable for vascular intervention or not. أول حاجة الانatomy. In anatomy, we must have an adequate access. The most common access for endovascular therapy is the common femoral artery. Mostly the right common femoral artery because it's easily accessible, and our hand is trained from the right side. Left side usually used for diagnostic angiographic catheter. Of course, this is not universal. It's need individual assessment. And usually the sheath French size from 20 to 24, depend on the case. The ideal access for the lumen has to be 7 millimeter or more to have a good caliber for the device to access. It should be not heavily calcified. There is no substantial tuberosity. And at least one side of the vessels is not diseased. And if the femoral or the iliac artery is inadequate, there's something called iliac conduit that can be done to insert the devices. And rarely, if all the iliac system is diseased, they can use distal aortic access. So this is about the access requirements for the endovascular. And now we'll talk about the aortic sealing zone in the CT. We should have adequate proximal and distal landing zone. The longer the sealing zone is preferable because it will decrease the endoleaks and will decrease the aneurysmal degeneration. So usually 2 to 3 centimeter landing zone is preferable for the stent. Of course, as we cover more aorta, it will increase the risk of spinal cord paraplegia. So, ideally, the landing zone parallel, distal to left subclavian artery and proximal to the celiac artery is the ideal landing zone. This is the landing zone for the aortic intervention. Usually, we have 11 landing zone. From 0 to 11, usually from 0 to 2 is the ascending, and that is required open surgery. From 3 to 11 is the endovascular approach. So when we have to, during the endovascular management of the thoracic aortic disease, when we put the stent from zone 2 to zone 6 or 5 or 7, we have a challenging area, which is the left subclavian artery. Sometimes, if the dissection, or if we need for any reason to cover the left subclavian artery, this can be done without any complications. But in a specific situation, covering the left subclavian artery might cause spinal cord ischemia or upper limb ischemia. So the situation that need revascularization of the left subclavian artery is important in few indications, like in the presence of a dominant left vertebral artery, or like a patient who has done a CABG with using of the left mammary artery, or in the presence of the left arm hemodialysis, or in the cases of aberrant right subclavian artery or hypoplastic right vertebral artery, or occluded internal iliac artery, or anomalous origin of the left vertebra from the arch. If we have any of these situations, then left subclavian artery revascularization is important. And we can do the revascularization with two options. Either we can do it with deep branching or hybrid technique, or endovascular. The deep branching, we have a different technique for that. For the deep branching, either we can do it carotid, or from internal carotid, or common carotid, or we can do it from the innominate artery also, but which is more challenging. You can see here a different type of deep branching hybrid technique for the left subclavian artery. This is in zone 0, deep branching thoracic aortic repair, and this is zone 1 from the arch repair, and this is a right to left carotid to carotid bypass. And the other technique, which is the endovascular technique that uses Chamonix stent, branched or fenestrated in the left subclavian to revascularize it. The common complication, of course, we have an early complication and late complications. The early complications are paraplegia, stroke, retrograde dissection, stent collapse, endoleaks, mostly for early event. The most common type of endoleak is type 1, we will discuss it now. And for late, the most common is type 2. And we have also access site complication. For late, we have retrograde dissection, also stent graft migration, fracture, aneurysm, aortoesophageal fistula, thrombus. All these are complications for endovascular. So the important we have to know is the types of endoleaks. We have 5 types of endoleak from 1 to 5. Type 1 endoleaks occur at the proximal or distal attachment site, which is mainly a failure of the endograft. And type 2, communication between a branch vessels that drain into the sac with the back bleeding from the, usually it's back bleeding from the intercostal vessels. Type 3 endoleaks at the graft-to-graft junction if you put 2 graft or 2 stent. Type 4 increase in the aneurysmal sac in the absence of without an identifiable endoleak cause. And type 4 is an endotension inside the graft, also without an obvious reason. So as you can see, this is type 1 endoleak, which is from the proximal or distal side of the graft. And type 2 branching, intercostal branching drain into the sac itself, and this too is defined as graft failure. Type 3 between graft to graft junction if we use 2 graft. Type 4, as we said, it's an increase in الو سامعين الصوت؟ الو؟
Yes, Dr. I will hear you. Yes, yes.
Okay. And you said type 4 is type 5 is the endotension in the stent itself, which also without notable cause. So what are the management of the different types of endoleak? Type 1 and 3 is the treatment failure, which need further management that increases because it will increase the risk of rupture, and it's class 1 indication, and the management with another endovascular stenting. Type 2, usually conservative management, yearly follow-up to detect any aneurysmal expansion. Type 4 and 5 usually is a benign course, need intervention only in the cases of aneurysmal expansion that يعني وصلنا للindications اللي هي 5.5 aneurysmal dilatation, then that's need intervention. So one of the most common complications also is the spinal cord ischemia. The risk factor that lead to spinal cord ischemia زي ما قلنا أول حاجة covering of the left subclavian artery. If the aneurysm is at the lumbar region, or if it's extend to compromise manual segmental artery, if the patient has preoperative hypotension, or if we had any embolization from the aortic atheromatosis lesion. So what we can do to prevent this spinal cord ischemia, we use neuroprotective strategies. We can increase the tolerance to ischemia or augment the spinal cord perfusion. Increase tolerance to ischemia, you can do it by two methods, either pharmacological or hypothermia. Pharmacological, we can use papaverine that increase the blood flow with the vasodilation, steroid, naloxone, and mannitol. And the hypothermia, this will decrease the oxygen metabolism required from the nervous tissue and will lead to prolonged the ischemic tolerance. Augmentation of the spinal cord perfusion, we maintain a blood pressure map from 90 to 100, and CSF drainage to decrease an intrathecal pressure perfusion. Then last thing, to maximize the oxygen delivery and keep the hemoglobin more than 10 milligram per deciliter, and the oxygen saturation more than 95. Now we have done with the aortic aneurysm and how to manage the aortic aneurysm with endovascular therapy. Aortic dissection, the anatomy and the landing zone almost the same, but with a few differences for indications. Usually the thoracic dissection are 65% ascending, 10% in aortic arch, and 20% with descending aorta. This is the CT of the patient showing dissection in the ascending aorta. As you can see, this is the flap, this is the true lumen, and this is the false lumen. This is MRI also showing the dissection. This is the false lumen, this is the true lumen, and this is the flap. This is a transvisual echo of type A dissection. As you can see, this is the ascending aorta, and this is the flap here. And this is aortogram also showing a dissection of the descending aorta, as you can see here. This is the true lumen, and this is the false lumen. This is the flap here. So the indication for intervention for aortic dissection in all patients with aortic dissection need medical therapy and blood pressure monitoring. This is class 1 indication. Type A aortic dissection surgery is always recommended. This is class 1 indication. In patients with acute type A and organ malperfusion, hybrid approach is class 2A indication. In uncomplicated type B aortic dissection, medical therapy is always class 1 indication. In uncomplicated type B dissection, using an endovascular therapy is class 2A indication. Type B aortic dissection, complicated endovascular therapy is class 1 indication. And the surgery is class 2B indication if you complicated type B dissection. So type A, class 1 indication, surgery. Type B, complicated, endovascular. Uncomplicated, medical therapy is class 1, and endovascular, class 2A. This is also the same guidelines. If it is asymptomatic, is class 3 indication for intervention. If symptomatic, class 2A indication. If traumatic, class 1 indication. If chronic traumatic, class 2A indication. Type B dissection, if it is with ischemia, is class 1 indication for intervention. If no ischemia, class 2B indication. In the aneurysm, if more than 5.5 with comorbidity, is class 2A indication. With no comorbidity, is class 2B indication. So what are the goals of treatment in aortic dissection? Number 1, we have to cover the proximal entry tier, and we have to expand the true lumen with restoration of the blood flow to the visceral vessels. And the number 3, we have to obliterate the false lumen to complete for complete thrombosis. So these are the 3 components that need to be reached in management of the dissection: coverage of the entry point, obliteration of the flow in the true lumen, and obliterate the false lumen. When these components are successfully achieved, aortic remodeling occurs with subsequent prevention of future aneurysmal degeneration and dilatation. As you can see here, this is the dissection. This is the proximal entry tier, and this is the false lumen. So stenting after covering the proximal entry tier. As you can see here, they did a translocation from the left subclavian artery to the carotid. So they did recovery of the entry tier and stent to restore the blood flow to the true lumen and compress or thrombose the false lumen. So we have, as we said, 3 types: uncomplicated type B aortic dissection, complicated, and chronic. For uncomplicated type B aortic dissection, the mainstay of therapy is medical management, but studies also say that prophylactic placement of endograft allow good remodeling of the aorta during the acute phases and subacute phases. Complicated is always class 1 indication for endovascular management. Complicated mean dissection with rupture or impending rupture or rapid expansion or malperfusion syndromes. It's also always associated with high mortality. So endovascular repair is the mainstay of management because it has the ability to cover the primary tier and redirect the flow into the true lumen, so eliminating dynamic malperfusion and also treatment of static malperfusion during the same interventional setting. So to know the difference between the dynamic and static perfusion, the dynamic, as in the picture, the dynamic malperfusion caused by branch vessel occlusion of the true lumen by the pressurized false lumen. Okay, as you can see, so this is the false lumen and this is the true lumen, and we have occlusion of the vessel, or the true lumen of the vessel, by the pressure from the false lumen. And the static malperfusion is progression of the dissection flap into the branch vessels. That will cause an ostial obstruction of the vessels with distal vessel occlusion. So these usually happen in complicated aortic dissection, and patient will come with malperfusion syndromes. So the mainstay management in these cases is endovascular management. In chronic aortic type B dissection, usually patients present with large aneurysmal component with multiple communication and entry tiers between the true and false lumen. So, and usually the dissection frequently extend to the abdomen with multiple fenestration between true and false lumen, with the exclusion of the false lumen is difficult. So endovascular management also is an option for that, but it's unknown whether the endograft of the entire thoracic aorta at the level of the celiac artery will be sufficient to cover all the entry tiers or provoke all the false lumen. But the publication, or recent publication, showed a good result with no morbidity by grafting the aorta from the left subclavian artery to the celiac axis. This is a case we did recently with Dr. Rida Jamjoom. This patient, 50-something, came with the, he did aortic co-arc 20 years ago, and after that, he presented with dilatation of the aorta. They did stenting for him, and 20 years later, he presented with stent fracture. So as you can see here, this is the stent fracture, 2 stents from in the arch and stent in the ascending. So there, between the 2 stents, there was a fracture, and he presented with the lower limb ischemia and dissection till the iliac arteries. So we put another covered stent in from the subclavian till the celiac artery. It was successful, alhamdulillah, and patient is doing fine. So last topic in the aortic disease is the treating atherosclerotic ulcer and intramural hematoma. Intramural hematoma is a hemorrhage into the media from the vasovasorum or a thrombosed aortic dissection, usually associated with ulcer and it's atherosclerotic ulcer. We did the same mainstay of management with endovascular grafting, and that showed good progression, good prognosis, and limit the progression of the disease. And it's good for a long-term management and healing to occur. An endovascular repair for the intramural hematoma and ulcer is for descending thoracic has proven good safe and good efficacy. This is result studies reporting endovascular management in different years from 2004 to 2009. The average age of the patient with the hematoma with chronic dissection usually from 60s to 70s. As you can see here, 30 days mortality almost less than 10% in most of the studies. And the successful rate is from 95 to 100%. So usually follow-up with the CT angio showed good lesion regression and thrombosis of the ulcer and the hematoma, and the clinical symptom usually resolved after endovascular management. With all that, the mortality with the ulcer and hematoma, it's still considerable. In patient presenting with symptom or other associated pathology is increased risk for poor outcome even after intervention. And I think that's all. We have finished the presentation. If you have any questions.
Thank you, Dr. Rasha. Very well informative presentation. Dr. Rida, please, if you have any comment.
ايوه شكرا دكتور رشا. very nice information. عندي few comments كده ويمكن ازود على كلام دكتور رشا اذا تدوني كده امانه اتكلم لو سمحتوا حتى تكون education ان شاء الله.
تبدا تاخذ معك.
اولا بالنسبه للاندوفاسكولار ريبير حق الثوراسيك انيوريزم is one of the most successful endovascular procedure that we do compared to open procedure من الباست. فلو نلاحظ التغيير اللي حصل almost 90% ولا 95% of the thoracic aneurysm كان أو dissection أو hematoma أو penetrating ulcers كلها 95% these days are treated endovascular. يعني هي للاسف انه الفاسكولار بيسووها these days والكاردياك ما بيسووها، بس الناس اللي بياخذوا سبيشاليتيز في الكارديا في الايورتيك سيرجري اكيد they will be exposed to endovascular procedures to be different than the old cardiac surgeons. and I think كثير من الفاسكولار الكاردياك new cardiac generation ان شاء الله يكون عندهم good training of endovascular procedure لانه it's taking over especially في الثوراسيك والايورتيك ارش. هذا بالنسبه كده كومنت في البدايه. بالنسبه للبرزنتيشن للدكتوره رشا it was nice. في few comments كده يعني just يمكن اوضحها زياده يمكن الدكتوره ما وضحتها. بالنسبه معظم طبعا CT angio is the gold standard that we use these days. الاكسس رايت ولا ليفت لما كانت بتقول most of the time right, but we really look at the anatomy انه اية الفيفوربل anatomy اني انا اقدر اعدي بسرعه وما يكون عندي مشكله في الالياكس. حتى sometimes في older patients and really calcified vessels اللي حتى they cannot tolerate open procedures ويكون we take the risk انه sometimes you rupture the iliac and you go in and then you repair it. ولا نحط endovascular stent graft and we open it all the way to have a good access للأيورتا. الإليال كوندويت أنا كده كأني حسيت إنه الدكتورة ما وضحتها إنه الأكسس إليال كوندويت. الإليال كوندويت معناه إنه we do a bypass graft. we saw a graft داكرون graft ولا PTFE graft للcommon iliac retroperitoneal approach and then هو الأكسس حقنا وبعدين we just cut off the graft ونخليه زي الباتش في النهاية على الcommon iliac. هذا بالنسبة للأكسس. الشيء الثاني اللي very important we look at بالنسبة in treating thoracic aneurysms اللي هو left subclavian. زي ما وضح الدكتورة very clearly إنه indications إنه when to revascularize the left subclavian artery. الصوت واضح بس عشان جاني تليفون فيه صوت واضح.
ايوه
ايوه دكتور معاك.
ايوه السباينال كورد سكيميا is one of the things. البلد سبلاي حق السباينال كورد زي ما كلكم عارفين انه يجي من السبكليفيان انتركوستالز والليما ودايركت برانشز من الايورتا. اهم برانشز تجي على الليفل اوف T10 T12 حتى نسميها الادم كويست. يمكن الاوبن كاردياك سيرجنز اللي يسوي اوبن usually they like to revascularize these vessels بباتش to يعني تفتح الجرافت حقك وتعملها زي الايلاند في الجرافت عشان to avoid spinal cord ischemia. فهذه يعني نعرف انه اهم بعد السبكليفيان اللي يجوا تحت على T10 T12. الشيء الثاني اذا كنا حنستخدم ستنت طويله تغطي لي السبكليفيان and it goes beyond 20 centimeter of the thoracic aorta, it is recommended to revascularize the subclavian for spinal cord ischemia. هذه النقطة الثانية اللي كانت عندي. النقطة الثالثة اللي هي زي ما وضحت برضو الدكتورة types of endoleak. type 2 usually it's early more than late لأنه it's the branches اللي في الساك حق الانيوريزم. so early حنشوفها بعد فترة ممكن يحصل ثرومبوسيس. ويوجولي إذا في more than one branch يعني two branches إن كانت lumbar branches أو thoracic branches direct كده حيكون في flow بين الاثنين فهذا يعطلك زيادة إنه يحصل لهم ثرومبوسيس. ف sometimes early intervention is okay with type endoleak but most of the time زي ما قالت الدكتورة we leave it and it will thrombose by itself. type 1 endoleak اللي هو من الديستال ولا البروكسيمال هذا إذا شفته intraoperative you have to treat it, you cannot leave it لأنه هذا it's still attention على الانيوريزم is there والفلو في الانيوريزم is there so you have to treat it. يجي ليت. متى يجينا ليت؟ يجي ليت بعد ما يحصل يا proximal or distal dilatation للأيورتا يعني نفس الانيوريزم كبر فيبدأ يليك تاني أو إنه حصل migration للستنت بسبب الانجل اللي تحط فيها ولا البلد بريشر ولا ما كان very well attached or sealed proximal. لاحظنا انه زي ما انتم عارفين الثوراسيك ايورتا الباثوفيسيولوجي حقتها the way that it مع كل heart beat it does not only dilate ويعني contract to dilate it also فيها rotation فيها فهذه كلها تأثر على الستنس وتأثر على الميكانيزم عشان كده برضو يحصل الفراكشر والأشياء دي. حتى وجدوا في الناس اللي نحط لهم ستنس في التروما اليونج patients اللي تحط لهم ستنس في التروما after a while عندهم higher risk of heart failure than the patients اللي ما تحط لهم ستنس عشان الباثوفيسيولوجي فرقت في الافتر لود على الهارت بيفرق معاه ودي الاشياء. فهذه كده بوينت كده حبيت برضو اي emphasize it. الدايسكشن بالنسبه للدايسكشن اللاندنج زون to seal is different والسايز حق الستنت الاوفر سايزنج حق الستنت يفرق معانا. انت ما تبغى usually في الانيوريزم تبغى good seal فيو اوفر سايز between 15 to 30% up to 30% من السايز حق الايورتا. في الدايسكشن you only oversize 10 to 15 عشان تخاف already انت جاله دايسكشن. one of the complication انه يحصل من type B يحصل retrograde dissection وتحول لtype A during deploying the stents. So you don't want to have that. So one of the things اللي use just انت تبغى بس push the intima to the wall and seal the proximal tear. ما تبغى oversize for a release تعمل seal زي الانيوريزم. فهذه كانت بوينت حبيت أقولها. الدايسكشن الشيء الثاني في الدايسكشن إنه إحنا these days we divide the dissection into acute, subacute and chronic. Acute اللي هي within a week, subacute up to 3 months وchronic بعد كده. ليه قسموها كده؟ اللي هي بالضبط مثل الفلاب حقك يصير stiff لما بعد 3 months الفلاب حقك يصير خلاص ناشف. عشان كده يصير it's difficult to put a stent أحيانا جوا عشان يفتح ما حيتفتح الفلاب حيكون ماسكه. ففي new ways و new technique إننا we tear الفلاب زي ما نعمل في العمليات في الأوبن سيرجري نعمل السباتوليشن حقت الفلاب عشان supplies both lumen true و open. هنا we penetrate من الترو lumen للفولس lumen ولا نخش في أي penetrating and we cut it down to make it open as a one lumen. Revascularization أيوة الشيء الثاني سوري بالنسبة uncomplicated type B dissections زي ما قالت الدكتورة gold standard till today is medical treatment unless we have other reasons. أنا أتوقع in the next حتى already بدأت in the next few years حتختلف شوية الكرايتيريا حق وبدأوا يتكلموا عليها وبدأوا يطلعوا radiological criteria للuncomplicated dissection اللي هم higher risk to have chronic complications. زي ما انتم عارفين one of the chronic complication حقت الدايسكشن is aneurysms. فالانيوريزمز almost 20 to 30% من الchronic dissection يجيهم aneurysms. ففي special radiological criteria بتطلع إن you early treat these patients with stenting عشان الريموديلينج حق الأيورتا يطلع نايس ويطلع هذا. سبحان الله I did few cases of uncomplicated chronic dissection كانت في young patients. الريموديلينج is you'll be surprised تجي تعد له السي تي بعد 3 months كل الدايسكشن healed ولا كأنه في dissection هذا. a new trend one new era إنه you treat uncomplicated dissection in a good risk patients و young patients وعنده radiological criteria إنه دي will have higher rate of complication. One point يمكن الدكتورة did not mention اللي هي النيو برضو اللي هي using IVUS اللي هو intravascular ultrasound. It is a new era إنه it helps us a lot in treating dissections عشان تشوف أنت الدايسكشن فلاب قفلته اللومن الانتري بوينت اتقفلت الإكزيت بوينت إيش أخبارها كيف الفلو فيها الفلاب بعد ما حطيت. one of the things that is important أحيانا لما تحط الستنت الفلاب حقك الديستال فلاب اللي نازل على الأيورتا على أبدومن الأيورتا افرق تماما. فممكن يقفل لك رينال ما كان مقفل يقفل لك SMA ما كان مفتوح. ف you have to be sure بعد putting الجرافت فوق إنه الفلو تحت is okay and you have to be sure قبل ما تحط الستنت إنه which is supplied by a true lumen and which is supplied by the false lumen. في radiological criteria للأكيوت والchronic dissection إنك تعرفها إذا كانت كده which supplied لأنه هذا حيفرق معك. أنت ما تبغى هو he's already good بالفلو من التو لومنز فما تبغى تقفل واحد وبعدين تتفاجأ بعد العملية. you have to be sure بالأشياء دي. وجزاكم الله خير وشكرا لكم. إن شاء الله كنت helpful.
يعطيك العافية دكتور رضا ما قصرت بصراحة.
الله يرضى عليك ويسلمك وشكرا لكم for the invitation وما شاء الله very high quality. اتبسطت أنا والله very high quality presentations.
الله يسعدك يا رب. دكتور معلش أنا عندي سؤال. When you do refer the patient for open technique, I mean for the descending aneurysm,
والله these days an open technique unless I don't have a real landing zone proximal we do it combined معاكم اللي هو يا انك تسوي لي elephant trunk
exactly
يا انك تسوي hemi arch ولا full arch وانا معاك intra operative I go and I stent the rest. انا في دانت والله مع الدكتور عثمان الراضي كم حاله في acute type A dissection extended all the way انه انت عارف الثوينج احيانا يكون very difficult في الديستال بارت كل الايورتا والتير فيو بوت ستنت على الاناستوموسيس حقك انك تساعد ما يحصل ليك وبليدنج والاشياء دي. والشيء الثاني مره واحده تظبط الدستل خلاص كانك قفلت الفولس لومن وبيشنت will have a very good prognosis usually.
Very well. Any more question?
Yes, if I may ask question.
Yes, please.
So, what about the role of aortic debranching and the role of endovascular type A treatment? Hear about new stent and if you have and aortic debranching.
السؤال لي انا ولا الدكتور رشا؟
لك دكتور او دكتور رشا اللي ما
اتفضل دكتور رضا طبعا.
طيب بالنسبه للايورتيك دي برانشنج sometimes احنا مع combined مع الكاردياك سيرجنز they debranch الارش vessels and we extend the same stent all the way to the ascending aorta. تمام. اذا كان مثلا عنده aneurysm extending all the way to the brachiocephalic طيب والبيشنت is not a good candidate انك تغير له كل الارش ده ومكمل وعارف انت لما نبدا بعد لفه السبكليفيان is very difficult انك to approach it in open procedure غير with from a sternotomy. ف sometimes الكاردياك يعملوا لنا deep branching from the ascending aorta and we extend our stent all the way to the graft لحد بعد الدي برانشنج على طول عشان ما تقفله. بالنسبه للستنت جرافتس الستنت جرافت للايورتيك ارش have been a while they are trying to have a good stent graft. هذا انا التريننج حقي كان في 2000 من 7 ل 9 انا really worked one of the guys اللي كانوا بيصمموا الدي برانشنج حق I mean الستنتنج for الاسcending aorta. اشتغلنا حالات وسوينا بس الريزلتس still today are not very good غير إذا البيشنت is not مرة candidate وتبت يعني تسوي له هي as هذا. طلعت جرافتس كثيرة وطلع برانش طلعت تخش من البريكيوسيفاليك تحط الجرافت and you extend في مليون تكنيكس ومليون جرافت طلع من ناحية fenestrated branched inner branched outside branched but till today still في سنترز يسووها لانه يبالها طبعا الاوردرنج فور المشكله الكبيره تيجي هنا الاوردرنج اوف ذا جرافت الاناتومي مو زي بعض لكل واحد فانت ترسل الام ار اي ولا السي تي لشركه كوك هي المين اللي تسوي دي الدي برانشنج ما في شركه ثانيه في العالم بتسويها. ترسل لهم الهذا ويحسبوها ويصمموا الجرافت بالضبط بالانجل بالديستنس بالهذا ومن فين حتخش فit takes time but الله اعلم اذا كانت حتيجي يعني till today 10 years من ولا اكثر من 10 years من يوم ما هذا ما didn't fly very well زي الديسندنج thoracic aorta. في دي برانشنج حق الابدومينال ايورتا كمان يستخدم انه تاخذ دي برانشنج مثلا عندك انيوريزم انفولفينج الفيسرال فيسلز اس ام اي ولا سيلياك ولا رينالز تعمل باي باس دي برانشنج ريتروجريد باي باس يجي له من الكومن الياك زي البايفوركيتد ولا ترايفوركيتد جرافت للرينالز وللاس ام اي ودي الاشياء وبعدين تقفل كله ذاك بالستنت This is another إذا كان قصدك على الabdominal part.
Very nice. Thank you.
شكرا.
Any more question? Okay, that's fair enough. دكتور رضا يعطيك ألف عافية. شكرا لك، شكرا لحضورك، شكرا لتعقيبك.
الله يرضى عليك ويسلمك وشكرا لكم.
الله يكتب لك الأجر. شكرا دكتورة رشا. I think that's the last, so we can conclude our session for today. See you inshallah next week.
في أمان الله. مع السلامة.
في أمان الله.